Hello, Achim.
Hey, Valerie, how are you?
Fine. I was just confirming if you can hear me.
I can hear you. Yes. Setup yako iko fiti siku hizi. You're good.
Oh, thank you.
Okay.
I can see our speakers already here. Please add them to be speakers.
Hello, Mr. Mapelu. Kindly, I've sent you a request to speak. Kindly, or you can also request to speak so that I can allow you from this end.
Hello, Ching. You can hear me?
Yes, I can hear you loud and clear.
Fantastic.
Hi, this is Charity. Can you hear me?
Yes, Doctor, we can hear you properly.
All right, thank you.
I think we can just start as more people join. I was trying to give more people time to join, but looks like they'll get us along the way, and the session is being recorded, so they'll be able to listen later. Because of time, I'd like us to start. So hello everyone and welcome to our X-Space on demystifying cervical cancer, myths and misconceptions. So join us as we delve into facts debunk myths, and empower one another with knowledge about this important health topic. So as we start, I'd like us to feel free. And today, the audience will be participating more because it will be like a Q&A kind of session where the audience will ask more about what they would like to be clarified on cervical cancer as we address the myths and misconceptions. So feel free to use the chat box, the comment section, and feel free to ask for the mic if you'd like to add some points, share insights, or some clarifications, or ask questions. So without wasting much time, I'd like us to move to introductions. And of course, I'll start with our host to welcome us. Thank you.
Thank you. Thank you very much, Valerie. And thank you, everyone, for joining. I wish to thank the speakers who presented themselves. And I'm sure today's discussion is one of a kind. It's a discussion that is quite relevant within the cancer space, and more specifically, even as we are dealing with the stigma surrounding cervical cancer. There's been a lot of myths and misconceptions about cancer generally, and also, and more specifically, about cervical cancer. And today's session had actually been requested largely by our audience, and I think it's right for us just to have these discussions and also just to get some more things clarified. Our speakers today will be able to enlighten us more in this, and I can't wait to just hear how the discussion goes. So everyone else, feel much welcomed. We are happy that you found time to join us, and let's dig in. I believe the time is far much spent. Valerie, you can just take over the session.
Thank you very much, Achieng, and thank you so much, our lovely speakers, for being here, and our amazing audience for taking your time to be here this evening. So I have a list of difficult terms in introduction, so I just request the speakers to kindly introduce themselves. I will not be able to read out. So please, Mr. Mapelu, would you like to go first?
Thank you, Valerie, and thank you, Achieng, for the opportunity to be on X Spaces today to have this conversation, which you rightly acknowledge to be a very important, vital, and urgent conversation that we need to have. My name is Elo Mapelu. I'm currently the chairman of Kenya Network of Cancer Organization, which is an umbrella body of about 60 organizations that are active in the various aspects of cancer control in the country. One of which is Hands of Kenya, where I come from, which I am also the chair of Hands of Kenya, is a blood cancer support group. And I worked with Hands of Kenya, this being my 16th year. And I'm really looking forward to a moment where we can be able to debunk some of these myths that are always there surrounding cancer, specifically cervical cancer, but as Achieng said, cancer in general. Thank you, Valerie.
Thank you very much. Dr. Kirui, please go ahead and introduce yourself.
Hi, everyone. I hope you can hear me. My name is Charity Kirui. I'm a medical officer. I have been working in the oncology unit for about a year now, and I can say that cervical cancer is close to me because when I was in med school, I volunteered under, I don't know if you know, Africa Cancer Foundation, where we have been screening people all around Kenya for cervical cancer. And right now I'm working in the oncology unit. So I think I know a bit, too, about cervical cancer. And I know that there are very many myths and misconceptions that I hear about every single day. People tell me different things about cancer. And I'm really glad to be here so that we can talk about it and actually put things to rest. Thank you.
Thank you so much, Dr. Kirui, and I'd just like to start with you. Please, for those who are new and those who don't know anything about cervical cancer, please just give a brief overview of what cervical cancer is, what myths are, what misconceptions are, and what's the difference, and why is it important to have this conversation today.
Okay, thank you. So I will start with Africa, because now we're in Africa and we're in a very prone area that has cervical cancer, and cervical cancer causing mortality due to the fact that a lot of women do not have access to screening services and also access to healthcare facilities. So I need you to know that in Africa, in every 100,000 women, 34 women will get cervical cancer. And in every 100,000 women, 23 of those women will die because of cervical cancer. So this makes you think that almost half of these women, if you get cervical cancer, you're bound to die. And that shouldn't be the case because of lack of, one, knowledge, lack of access to healthcare facilities, lack of access to screening services. So cervical cancer is a form of cancer which affects your cervix. Your cervix is basically found in your genitourinary tract. So if you look at your genitourinary tract, there's something called the uterus, then below it is the cervix where we find it, and the vagina. So cervical cancer is caused by something called HPV. HPV is human papillomavirus. It is one of the most common sexually transmitted infections known. You know, you can say there's chlamydia, there's gonorrhea, but HPV is globally one of the most common sexually transmitted infections. And you see, having one of the myths, yes, is that if you have HPV, you're going to get cervical cancer, and that is a lie. Because the infection is sexually transmitted. One, you get HPV. That does not necessarily mean that you're going to get cervical cancer. So before we go into that, I just want to define what myths and misconceptions are. You need to know that myths usually come from a place of tradition. That this is something that masses of people have believed. They don't even know the origin of this myth. Especially, let me give an example of HIV. When we were young, we used to know that, especially this is a time when there was a lot of stigma when it came to HIV. We used to know that this particular person, contact to, if they just look thin, they look like they have HIV. Or if you just sit next to a person who has HIV, you're bound to get HIV. So you need to know that it's usually just based on things that are not factual. They do not have evidence, and we don't know the origin. Probably it was just started as a rumor by someone, and it became something that a lot of people know. And so now it becomes a part of our daily lives where we think if you sit next to a person who has HIV, you're going to get HIV. When it comes to misconception, it's just basically misrepresentation of the truth, meaning there's something and you're just misrepresenting it based on your thinking and your understanding. For example, when we used to think HIV is a death sentence. No, HIV, yes, can cause you to die, but that does not necessarily mean it's a death sentence, especially now that we have ARVs and now that we have medication that can help people live very long when you have HIV. So that's how we're going to talk about the myths and misconceptions. I've been told it's a Q&A, but I had a few myths and misconceptions about cervical cancer that I wanted to discuss. So it's up to you, Valerie, to tell me if I can go ahead and discuss the ones that I have, or it was meant for people to ask me and we delve into them.
Thank you very much, Daktari. So before we continue, before even I answer your question, I'd like to ask Mr. Mapelu if he has any definition or something that you may have missed, or anyone else who has something to add before we proceed.
Thank you, Valerie. Dr. Kirui has put it very clearly. The only thing I might just want to add is the fact that the statistics are really scary. Seeing the number of people who get cervical cancer in Africa, as Dr. Kirui had said, 34 in every 100,000, and 23 of those ending up, dying, is a statistic that makes us really get concerned. And the reason being that unlike various other cancers, cervical cancer is a fairly well treatable cancer. If it is got early, then it is treated and fairly well treated. But there are other important things that I'm sure we will be unpacking as we go. That there exists a vaccine for cervical cancer, which helps to reduce the cases of cervical cancer. But the uptake of the vaccine in this country has not been as impressive as we would have wanted it to be. And if we take a number of things out of this conversation today, one of which we must remember to put very close to our hearts is that there's need for vaccination, because vaccination is available. It is there. There's need to be vaccinated, especially for the young girls who are the target. The target of the campaign that was started fairly recently by the government, because once you are vaccinated, then the chances of one developing cervical cancer reduces by a big percentage, and we hope that we'll be able to achieve up to 90% of 15-year-olds getting vaccinated, which will be a very big push towards eliminating cervical cancer. Valerie?
Thank you so much. It's important to also note something about the vaccine. So please, you mentioned that young girls, so just clarify the age that needs to get vaccinated, and if it's also important for boys to get vaccinated.
It is actually important for boys as well. I'm sure the campaign that was started by the government some time ago focused on the girls, but it was purely because of availability of what was the stock that were available. But it is recommended that it's also given to boys. That way, of course, then we'll be able to eliminate the chances of someone developing cervical cancer from a HPV infection.
Thank you so much. So getting to Dr. Kirui, you wanted to mention some myths and misconceptions that you already have, and I think it's important for you to just mention them, so that if the audience maybe had the same, then they'll have fewer questions to ask. So please go ahead.
Okay, thank you. So these myths and misconceptions are basically things that I have collected from patients who have had cervical cancer, relatives of these patients, friends, family, because I was asking people, what do you think about cervical cancer? And these are things they were telling me. The commonest thing I had is that if you have HPV, you're going to get cervical cancer. And that's a myth. You see, HPV, once you get the infection, three things can happen. Either one, you do get precancerous lesions, and that takes a long time. It takes around 3 to 7 years for changes to happen in your cervix for it to actually become cervical cancer. Two, your body can get rid of it by itself. Especially people who have good immunity, your body just gets rid of HPV by itself. Or three, it just remains dormant and nothing will ever happen. So if you do get HPV, it does not necessarily mean you're going to get cervical cancer. But if you get HPV, and you see, this is why screening is very, very important, because you see, if you get HPV today, 2024, and then we screen, let's say, every 3 years, so the next screening will be 2020, in 3 years it's going to be 2027. If we screen and we find precancerous lesions, we can treat the precancerous lesions. So if you get HPV, it can develop into precancerous lesions. Once we do the screening and we get precancerous lesions, we can treat it. But if we do not treat the precancerous lesions, it can develop into cervical cancer. So you having HPV does not necessarily mean that you're going to get cervical cancer. Another thing is that HPV only affects people with multiple partners. Well, this is kind of true, because you see, there are certain risks of you getting cervical cancer, and one of them is having multiple sexual partners. But that does not mean that someone in a monogamous relationship cannot get HPV. You can get HPV from having one partner. You can get HPV, and you can actually get cervical cancer if you do not treat the precancerous lesions that are caused by HPV. The third one is that a pap smear is needed every year. That is not true. But this is only true for people who are immunocompromised. We usually ask a lot of patients who are immunocompromised, examples for patients who are HIV positive. We tend to tell them that because your immune system is not that good, that means the risk of your changes happening in your cervix to form cancer are at a higher risk than someone who is not HIV positive. That's why we encourage patients who are HIV positive to get screening every year. But if your immune system is good, we encourage you to get screening after every 3 years. So another myth is that if you are not sexually active, you do not need screening. You will not get cervical cancer. That is not true. Though it's true that the commonest way of getting HPV and thus getting cervical cancer is through sexual activity, there are other ways that you can get HPV. Sometimes even through fomites. Research has shown that you can get through fomites, through fingers, through skin-to-skin contact. So even if you are not sexually active, it's good for you to get screening. And we can talk about screening if you give me time, about when we start screening, at what age you should start screening, who should get screened, and after what duration you should get screened. So it doesn't matter your sexual history. If you're sexually active or not, you should get screening for HPV. Another one is that older women should not get pap smears or do not get HPV. So the commonest age in which cervical cancer is found in women is around 35 to 45 years of age. That is like the commonest ages where you'll find a lot of people are getting cervical cancer. Research shows that women who are above 65 are at a lower risk of getting cervical cancer, but that does not mean that they will not get cervical cancer. That's why screening is very important. That's why for women who are 65 and above, if for the past 10 years that you've been doing screening and nothing was caught, then for you, your risk is very low of getting cervical cancer. But if you're 65 and you have not been doing screening, you can still get cervical cancer and you can still do screening, which is important for all women to get screened. One important thing we need to know is that a lot of people believe that cervical cancer is hereditary. Unlike breast cancer is definitely hereditary. If your mother had it, your risk of you getting breast cancer is also very high. But remember, cervical cancer is caused by HPV, which is an infection. So it is a transactional thing. It's a horizontal mode of transmission, meaning it's sexually transmitted and it's not hereditary. This does not mean if anyone had any cancer in your family, you should always be aware that even you could get any form of cancer. For example, let's say your father got colorectal cancer, you could get cervical cancer. If your mother had breast cancer, you could get colorectal cancer. But this does not mean that if your mother had cervical cancer, definitely you're going to get cervical cancer. It just means that if you also need to be on the lookout for cervical cancer, but it is spread through HPV. It's not because of hereditary genes or anything. Another thing that people believe that, because you see a lot of mothers, especially where I work in the rural areas, they believe when you get cervical cancer, you're definitely going to die and that it's not treatable. Immediately you get any form of cancer. And a lot of people, especially in the rural areas, believe that immediately you get any form of cancer, you're definitely going to die, that it cannot be treated. Cervical cancer, if found early, in the very early stages, and I insist, this is why screening is very, very important, because if you get HPV, you get precancerous lesions, and we find precancerous lesions. Precancerous lesions are very treatable. It's very hard to treat cervical cancer, especially cancer that has metastasized. By metastasis, I mean it has spread throughout the body. So cervical cancer is treatable if found early and depending on the stage that you have found the cervical cancer. Not all forms or not all stages of cervical cancer can be treated. Because cervical cancer stage 4, this is a form of cervical cancer that has spread maybe to the lungs, to the liver, different parts of the body. That's when most of the time we do palliative or rather end-of-life care. But if you find precancerous lesions, you find cancers in like stage 1, stage 2, early stage 2, these things can be treated. That's why it's important to tell patients, go for screening. If we find cervical cancer early, we can treat it depending on the stage. Another thing, depending on the HPV vaccine, a lot of people believe that if you get the HPV vaccine, you do not need screening and you're not going to get cervical cancer. This is a lie. Let me take an example of the TB. All of us if you actually got the TB vaccine when we were young, if you got the TB vaccine, it does not mean that if you expose yourself to someone who has TB, that you're not going to get the TB. If you expose yourself to someone whose cousin has TB, you could get the TB. So this means if you get the HPV vaccine, and let me just talk a bit about the vaccine. The vaccine screening, giving of the vaccine can start as early as 9 years of age. But in Kenya, the average we're giving is around 10 to 12. And we give it to both boys and girls. So early giving of the vaccine starts at 9 years of age, but averagely we're giving at 9 to 12 years of age. Then there's something called catch-up. Catch-up is where catch-up vaccination. This means that If you were to get a certain vaccine at a certain age and you did not get it, you can now catch up and get it. So this is especially given for people who are the age of maybe 13 all the way to 26. Those are now where we think, yes, this is a vaccine. It could be useful for people who are the age of from 9 years all the way to 26. But currently, the current guidelines don't recommend vaccination of women above 26, and they believe that the efficacy of the vaccine is not as good, especially if you're like 26 and above. They assume that you've already been exposed to HPV. But this is also depending on your gynecologist. If you see your gynecologist and they decide, okay, you might consider yourself to get the vaccine. So for 26 and above, because I know HPV vaccination for people who are not children, it can be expensive because I've heard of vaccines which are 15,000, which are 20,000. So for that, it depends on the cost and risk. You visit your gynecologist and you both decide, okay, am I at risk of getting HPV? Do I need the HPV vaccine? So it's very important if you're 27, 26 and above, it's dependent on individual, especially if you have a negative HPV test and a negative pap smear. That would be very good for you if you got the vaccine. Those are some of the myths that a lot of people have been telling me, where they got it from school, whether they got it from home, whether they talk to their friends about it. These are the most common myths and misconceptions that I have been getting. I think those are the ones I have. Thank you.
Yeah, Valerie?
Yes, please.
Thank you. Dr. Kirui has actually mentioned quite a number that always being asked out there. We will keep hearing of those concerns that she's brought out very eloquently. Just a quick addition. I know there are some people who think that after the HPV vaccine, and Dr. has addressed that they are now free to engage. There is a myth that after the vaccine people become a bit less careful. Well, you really can't help people much, but Dr. has alluded to that and has said that it is important that someone takes care of themselves even after they have been vaccinated. There is another one that I heard, and Dr. will help us to reason through this one, that HPV is caused by bad hygiene, because for the most that I know that hygiene has nothing to do with that, and we haven't come across any case of hygiene and cervical cancer. There's no correlation, despite the fact that that is a myth that does round a lot out there in the few places that I've been to. They just say huyu anakuanga tu hivyo tu, si msafi, things like that. But there's no correlation between hygiene and cervical cancer. And then there's an article I read recently, just about 2 weeks ago, that now you can do testing through urine sample. I know it's something that is on the works very soon. I think once that comes out, we'll be able to get better details on that. And that is because some people imagine that a pap test is is painful, it's uncomfortable. Now there might actually very soon be a possibility for someone to use a urine sample, which is much more easier for people to do. But even then, I think the pap test is not painful. Slightly uncomfortable maybe, but it's not painful. That's one of the myths that I've heard out there, that it is painful. I think that's just what I wanted to add, and also to say that it's important to be able to educate people on this, because the uptake of especially the vaccination is really low. To improve that uptake and to make sure that we are winning this battle against cervical cancer, we need to educate people on the effectiveness of the vaccine, as Dr. Kirui has rightly said, and also to let them know that it is actually supposed to be used on both boys and girls as much as that is possible. Valerie?
Thank you so much. Daktari, would you like to add
Yes.
or clarify?
Thank you, Mr. Mapeli, for that. For the issue of hygiene, especially when relatives come, they tell me that probably ni uchafu because they'll say that there's a bad smell coming from down there. I think a lot of relatives and patients correlate that lack of hygiene to the actual smell that comes from the cervical cancer. Especially if there's a wound or there's something going on in your cervix, it will emanate a bad smell. That's why I think a lot of patients will say probably ni hygiene or it's uchafu. But again, HPV is sexually transmitted and it would not be caused by lack of hygiene. Yes, thank you.
So, Daktari, apart from the contact, the sexual, the transmission through sexual intercourse, and taking care of our sexual health, so what are some of the more risk factors for cervical cancer?
Okay. So when it comes to the risk factors for cervical cancer, there are very many, but the most common risk factors is one. The main risk factor for getting cervical cancer is infection with HPV. That is the commonest risk factor, and it is the only risk factor that is like completely. If you get HPV, even though it does not necessarily mean you're going to get cervical cancer, but that is the biggest risk of you to actually get cervical cancer, having HPV. Two, having multiple partners. The more partners you have, the more at risk you are of actually contracting HPV. Smoking. Smoking is one of the biggest risk factors for getting cervical cancer. Immunosuppression. If you are, especially when it comes to, I really tend to insist on HIV patients getting screened every year because a lot of patients who come presenting with cervical cancer, maybe around 50% of them are HIV positive who are not on medication. So immunosuppression is a very big risk factor for getting cervical cancer. Smoking, having multiple partners, HPV itself, those are some of the commonest risk factors for getting cervical cancer.
Okay, so from the audience, please mention any myths and misconceptions that you have, something that has been bothering you and you'd like it to be clarified. Please go ahead and you can request for the mic if you'd like to speak. You can also use the comment section to put down your comments, your insights, your questions, anything you'd like to be clarified. Meanwhile, you can keep using the hashtag her reason for being to keep the conversation going. Please feel free to ask. Yes.
Oh, but yeah, Valerie, I just wanted to ask Dr. Kirui, perhaps she may have come across this. I find people always talking about use of oral contraceptives and it being a risk factor to them getting cervical cancer. I know there are various methods for contraception, and I'll advise them to talk to their doctors about it, their gynecologists, and if need be, they can use the non-hormonal ones. But Dr. what do you think about the correlation between oral contraceptives and cervical cancer? Have you come across such cases in your practice?
In my practice, you'll find maybe one will say that they used oral contraceptives for maybe 2 years and stopped. But research shows that for people who use oral contraceptives for 5 years or more are at a higher risk of getting cervical cancer. From the research that I've done and from studies, it shows that if patients are using combined oral contraceptives for more than 5 years, their risk of getting cervical cancer goes up. But in my practice, I haven't gotten any patient who was on combined oral contraceptives for more than 5 years and got cervical cancer. No, I haven't had any patients like that.
Yeah, I think it's important to put it out there because, I've come across people who claim that it is because of the oral contraceptives they used And unfortunately, that's out of contraception is the cheapest form of contraception that we have, because if you tell them to use the device, the IUDs and the other forms of contraception, most of them will not be able to afford. So if that is a real case, and if it's a real worry, should we not then look at that and probably try to find out if there are more studies that relate to that, and see how best to advise our women? Because you can imagine in a place where someone cannot be able to afford any other way, any other method, then the only way to do that then becomes a risk factor. I think that there is need for more study on that, so that we are able to advise people effectively.
Thank you for bringing that. That has been our concern, and especially even with the stories that we normally do. There are some who claim that it's because of the contraceptives they were using, that's why they were able to maybe get the cervical cancer. But we need more studies on that so that it's clear. I'm not seeing any questions. Oh, Evelyn, would you like to say something?
Yes, I'd like to say something.
Yes.
Well, or rather to seek clarity on two things. One, is there a benefit of vaccinating women who are already sexually active? And secondly, would there be, I know there are countries that vaccinate boys as well. Does it have an impact on the burden of disease in women? Thank you.
Thank you for the question. Daktari or Mr. Mapeli, anyone can go ahead and answer.
Okay. So I had talked about this vaccinating of women who are already sexually active. That is why I talked about catch-up vaccination, where if you had not received the vaccine at the appropriate age, which is around 9 to 12 years old, you get it at 13 all the way to 26. They say that now studies have shown that for women who are 26, 27 and above, they usually don't recommend vaccination. Why? One, because they assume that these women have already been exposed to HPV because they're already sexually active. Two, also the cost, because if you're going to, because the efficacy of the vaccine reduces as you age, as you grow older, because of the fact probably you've had children, you're already sexually active, so you've already been exposed to HPV. And you see, the thing with the vaccine, if you have HPV, it does not stop progression of HPV, neither does it cure HPV. So you need to know that if you're already exposed to HPV, you getting a vaccine would not be highly recommended. But now I've seen in hospitals where, yes, you're 27, you're already sexually active, okay, that's fine. So what we're going to do, we're going to give you your HPV test. We're going to do something called co-testing, which means you do the HPV test and we do the pap smear. If both of them are negative, we can decide, you know what, okay, fine. You want the vaccine, okay, you can get the vaccine, but you need to know that the efficacy of the vaccine is very low if you've already been exposed to HPV at the age of 27, at the age of 30, at the age of 45. I hope that answers your question, the first question. So the second question you had asked about burden of disease when it comes to men. So one,
let me clarify.
Yes.
In the country, I know there are countries that vaccinate boys.
Yes.
Does that have an impact on the burden of disease in women because of the way the disease is transmitted?
Mm-hmm. Well, one, the reason we vaccinate boys, one, yes, we're reducing the burden of disease, one. And two, HPV does not, you see, HPV has very many strains. It does not only necessarily cause cervical cancer, but it does reduce the burden of you spreading the cervical cancer. Because you see, HPV also causes other forms of cancers in men, especially men who are homosexuals. Now, those men having sex with men are at risk of getting HPV and getting anal cancer, penile cancers, oral cancers. That's why we're also vaccinating men. One, because HPV does not only cause cervical cancer, and two, it reduces the burden of transmission. I hope that answers your question now.
I think that's very clear, and I may not even add much. Probably just to say that by reducing the circulation of the virus in the population, it ends up meaning lowering the disease burden. It's kind of like getting a herd immunity of sort. But I haven't come across any studies or any data that shows that these figures are this way because we immunize boys. It only makes sense to do that, and I'm sure maybe it is something that is still in the process. Very soon we'll probably be able to get some solid data that proves that vaccinating boys was responsible for reducing the burden by this much. But it makes sense to reduce the circulation of the virus in the population. Valerie?
Okay, I hope that was well answered, Evelyn. Are you satisfied?
Perfect.
Okay, since
Thank you.
I'm not seeing any other... Yes, please. Okay, so I'm not seeing any other question. I know they'll be coming as we proceed. So, Mr. Mapelu, how do these myths and misconceptions impact cervical cancer awareness and prevention efforts?
Like I said, Valerie, we are not at where we will want to be. There's a target of making sure that we have vaccinated the 90% of young girls by the age of 15. At least 70% of 35 to 45-year-olds have been screened. 90% of those who've been positively identified have been have been treated. Is the 90-70-90 goals. We've not really managed to get even halfway there, and that's because of these various myths and misconceptions. Because if someone, for example, relates cervical cancer to a curse, because we've had people relating this to family curses or promiscuity, then they will be shy to seek help. They'll be shy to go to a health facility and seek to talk to Dr. Kirui or someone who will direct them to getting correct care. So that has really hampered our achievement of the target that we hope to in trying to control cervical cancer. So and like I said in the initials, there's real need for us to try and debunk these myths as we go ahead and create awareness and educate the public about this. It's important to help them understand from a knowledge perspective that it is not the way they've been thinking about. We give them correct information so that we're able to create more awareness. We're able to reach our prevention targets that are set out for us. Valerie?
Daktari, is there anything you'd like to maybe add?
Yes. I'd like to say that a lot of these myths and misconceptions sometimes come out of a place of lack of knowing things. So you'll find a lot of patients don't know what is true and what is false. So if you have a patient who believes that if I get HIV or if I get cervical cancer, I'm going to die, these patients are not even willing to come back to hospital to seek help. These are patients who will just go home and try mitishamba. You see, a lot of these things are just caused by not knowing. And you see, if these patients do not know, they're not going to access these services. They're not going to take their children to get HPV vaccines. They're not going to tell their neighbors, oh, you know what? HPV does not necessarily mean you're going to get cervical cancer. They're going to think that boys should not be vaccinated. A lot of people also do not know that boys should be vaccinated. They just believe that cervical cancer ni kitu ya wanawake. You see, people do not have the knowledge and the understanding of cervical cancer and the implications it has on screening, it has on health, the implication it has on overall on the whole community. People would really be getting healthcare services, getting screening services. So a lot of the times I just tend to think that a lot of people do not know. So you see that lack of knowledge is what causes a lot of these things to be rampant. Back to you, Val. Thank you.
Thank you. And there's a huge gap. There's a gap in information,
Yes.
especially in communities. And we may assume that most people know even about cervical cancer. And unfortunately, while doing our community engagement activities, we came across people who do not even know where the cervix is, what cervical cancer is. So how then will they know about the vaccine, and how will they accept the vaccine in the community? How will they tell it to their people, their family members, the community at large? So there's still a huge gap. And so what are some of the effective ways to educate people about cervical cancer and dispel these myths in the community where awareness is very low?
I believe that education starts with one person. It starts with you, Valerie. It starts with Mr. Elo. It starts with me. If I know something about cervical cancer, I'm going to tell the next person. I'm going to tell them, you know what, by the way, cervical cancer is this and this. And I'm going to talk to women. You know, it's our responsibility as healthcare workers, as people who are meant to do outreaches and go into the community. Our job is not just to use social media, because you see, social media is not being consumed by everybody, especially the large number of people are people who do not have access to internet, especially people in the village, mothers who come in end stage cervical cancer do not know what cervical cancer is. They just think they had a bad smell or they were bleeding too much. They do not know these things. It is my job as a healthcare professional to take myself into the community and tell them, Wamama, this is cervical cancer. Cervical cancer does this. Women who are pregnant, coming in for ANC, I tell them there's cervical cancer. You can get cervical cancer. Cervical cancer is this. It should be put in a daily activity where if women are coming into ANC and they're pregnant, I tell them cervical cancer is this, cervical cancer can do this. You go on TV, you just need to be constantly talking about it. If something is being constantly talked about, people are going to be like interested and wonder, what is this? Screening. Screening of mothers is so important. It is very important for people to be screened, but I believe the most important factor is teaching people. If I'm a mother myself and I have a 12-year-old child, I have an 18-year-old girl, if I take her for vaccination, I shouldn't just tell her, tuende udungwe, usipate cervical cancer. My child needs to know that this is cervical cancer and this is what happens, so that the next day when she goes to school, she'll tell her friends, oh, by the way, mimi jana nilidungwa, mbona ulidungwa? You see, information spreads so fast. It was about cervical cancer. Maybe that child will go home and tell their mother, Mom, kuna rafiki yangu alidungwa shule, cervical cancer. Mimi naweza dungwa. It is very important to educate. If you educate people, you educate women and men about cervical cancer. I believe cervical cancer, it will reduce. If we educate mothers, we tell them that this is cervical cancer. This is what happens when you get HPV. It can be treated. I believe knowledge is power. Thank you, Paul.
Yeah. Thank you, Doctor. In addition, Valerie, let me just say this quickly. We have also at SCANCO, we have also tried to sensitize the community health volunteers because in the current primary healthcare system, they are extremely important at the base of that pyramid, because they are the ones who get in touch with patients first, and we want to give them we will not give them a lot of information, but we'll give them enough that will help them be able to advise the patients or the communities out there effectively. I know it's going to be a long a long shot for us, but we've started training in the nearby county. We hope that we'll be able to train at least 100 out of the close to 1,000 CHVs in Kajiado County, and then hopefully over the next year or so we'll be able to have a model that can be able to take us to, all the counties and have a few CHVs trained in cervical cancer. Is one of those cancers that can easily, be controlled because of the various possible ways that we can be able to do that. So we are doing that, but you also want to encourage you to continue online voices to continue taking up this space and informing the public about it, because it's important for them to have a place where they can find a good information about cervical cancer. So we continue on with what we do. We continue on one-on-one information. We continue in the corporate approach that we've taken as Kenco, and also invite more people to work together with us towards making that a reality. Valerie?
Thank you so much, and for the great work you are doing so far as Kenco. And let me check if there are questions. I'm not seeing questions. People are saying the audience. From the audience, this is a very insightful session, very informative discussion. Myths and misconceptions results to reduced number of asymptomatic women visiting the hospital for screening. Or the point just came up that you must experience the signs and symptoms for you to get to be screened. And one of the survivors told us that she did not have any signs, she did not have any symptoms, she did not feel any pain, but she had cervical cancer. So it's really important for us to go for regular screening so that we are able to. Yeah,
true, Valerie. Early stages of cervical cancer are really symptomless. So unless someone goes for screening, they may not be able to be picked up early enough. Dr. What do you think?
Yes. When we were in school, we learned that cervical cancer is sometimes known as a silent killer. A silent killer meaning you'll just be normal, living your best life, and there's something going on in your body. The cervical cancer changes, the cervical abnormal cells are changing, things are happening in your body, and you do not know. A lot of women may be asymptomatic when they have cervical cancer, while others are symptomatic. Yes, it's true.
Thank you. And so, are there specific populations or demographics that are more susceptible to believing myths about cervical cancer, and how can we tailor education efforts to reach them?
By certain demographics, do you mean like in Kenya or like a certain age group? What do you mean exactly, Pal?
Could be age group, could be a certain religion, could be a certain population that may not be very welcoming to our information, and so to be able to maybe get to them, to get to them to understand, we have to tailor our information and maybe get into their culture, and that's like.
Okay, so the thing with cervical cancer, haibagui, it can get any woman at, especially like I told you, the age between 35 to 45 is where we have the most prominent number of cases of cervical cancer. However, you'll notice that women who have a lot of children, because also that is a risk factor. Having a large number of multiple pregnancies can be a risk factor for you getting cervical cancer. Precancerous lesions, generally, because probably in Nairobi, you'll find them because a lot of women have access to healthcare services, have access to screening services. So it's easy for them to get screening, and we get precancerous lesions. Now, cervical cancer, especially end stage, you tend to find in a lot of rural areas, because you'll find a woman came probably with a bleed, and then she was told it's okay, go home, and then she comes probably 1 year or 2 years later when it's now she has metastatic cervical cancer. So I've seen precancerous lesions a lot. I tend to find them in urban areas, but fully spread cervical cancer I tend to find in rural areas, and this is probably because of lack of access to healthcare services. This does not mean that in urban areas you're not going to get full-blown cervical cancer, because, like, again, sometimes it's an asymptomatic thing. You could be having the cervical cancer without the symptoms. Valerie?
Thank you, Daktari. And by this I meant, is there a specific population maybe that may be very much into the myth that they will not want to listen to our information, and how can we approach them? Talking about those who are so much into religion and they may not want to listen to even to science. They want to be prayed for and they do not want to go to hospitals. So what approach do we use?
A common thing that I found. Oh, it's okay. Samatali, you can go.
Well, Dr. As you prepare to answer that question, maybe then I can also mention something. I think it was 3 weeks ago we started the training with Kajiado County, and one of the challenges that we faced is how do we communicate to the public, because we've given them some good information, but how do they deliver this information to the public? Kajiado, most of the communities there are fairly conservative. They will not even have a way to communicate, about cervical cancer, about the cervix. How do you start that conversation? How do you even mention some of those unmentioned places? It's a bit of a challenge, but we gave them the homework to go and find out how best to break this in a language that will be acceptable in those very conservative communities, because there are those who will not even want to discuss anything below the belt. But we have to have a way to do that conversation. So I know it may not come from us. How do we communicate to them? Specific areas, specific people may be able to find a breakthrough in communicating the same in their neighborhood, as long as they are backed by the kind of information that we provided, because we took educators from the Ministry of Health, and they were able to break down cervical cancer, and the other one they had a chance to discuss with the breast cancer. They were able to break that down very well for them. So now it is up to them now to take it home and find a way to communicate that to their communities, knowing the kind of barriers that are there in terms of communication. There are some serious barriers, but then they'll be able to figure out how to overcome those barriers and be able to communicate that to them. Dr.
Thank you, Mr. Mapel. And it's true, he's saying about how certain communities are very conservative about receiving education, especially when it has to do something with the reproductive system. This is probably one of the biggest challenges when you're talking to certain communities, because they think it's a taboo to talk about it, or it's something that's wrong. And so most of the time, if they do get problems, especially in the genitourinary area, they do not come to hospital. So that is still a challenge that we're trying to work on, trying to communicate, but especially with community health volunteers, people who are known in the communities. These are people who sometimes are confided in by these same people. So having them, these volunteers, and having them go into the communities and help us talk to the individuals is very good for us. Another challenge that we're really experiencing, especially in the rural areas, is use of local medication, meaning dawa za kienyeji. A lot of patients come in, we tell them diagnosis, they'll tell us, okay, tutarudi. So we tell them it's cervical cancer, it can be treated, and immediately they hear cancer, they say no, tutarudi, and they go and start using herbal medication. Then they come back 1 year later now, when probably the disease has progressed. So we're really trying our best to educate patients and tell them dawa kienyeji is not the way to go, even though some really believe in it. Especially you'll find a patient who has stage 1 cancer, they hear it's cancer, they go home, dawa za kienyeji, come back, it's stage 4. Yes, this is something that can be treated and it's preventable. So this is something that we're really trying to talk to people here in the village about. Valerie?
Thank you so much. I think it's important to involve them, to get the ways from them, because they're the ones who know the community, and especially we can go to the community through the CHPs, community health promoters. They know them very well, so we can be accepted at least. But it's not easy, as you've said, both of you. We are trying. We cannot give up on on them. I don't think I have much from my side. Let me check from the audience. No question. Oh, there's a point. Integrate cervical cancer screening services with other services where we can target women like family planning, NCD clinics. What are your thoughts?
Yeah, well, I know that has been mentioned, and we've even gone further to have a conversation with NHIF. We hope that the successor to NHIF, the SHIF, will also see the point that we're putting down there, to see that when someone goes, they get that package that allows them to have screening, because part of the reason why people don't get screened as frequently as they should is obviously the cost, and they only wait for when there is a free camp for them to go get screened. But otherwise, they will not be able to get screened because of the costs associated with that. So we are hoping that in the new rollout of cover by the national insurer, screening will be part of that. Of course, other diagnostics will also be covered. As was promised, we hope that will be effected, but we're following it closely with NHIF to make sure that is, so that we are able to effectively integrate screening and diagnostics with other, with other primary care that is often in the various primary health care facilities. So that if it goes through, then it will be a big plus to us. Well.
Okay, Daktari.
Yes, I agree with Mr. Mapendo about that. And if you notice that a lot of medical camps these days have included cervical cancer screening, and that is very commendable. I think it's very commendable of people to be aware that cervical cancer is something that needs to be talked about and it can be treated. I think that's really important for us to note.
I think we lost you, Daktari. Are you still speaking? Okay. Can you get one or two comments or questions from the audience? Please go ahead and raise your hand if you'd like to use the mic. Achin, can you hear me?
Yes, I can hear you, Valerie.
I thought I was on mute. Sorry. I can't see any questions or contributions from the audience.
There's a speaker.
Who?
There's someone who would like to speak.
I can't. Who is that? Oh, Caleb. Caleb, please go ahead.
Thank you. Thank you very much. Good evening, everyone. It's a pleasure to be here this evening. Greetings from Togo in West Africa. I just wanted to appreciate this initiative and appreciate Being Africa for a very, very, very insightful session. I came in a few minutes after you started, but I must assure you that I've learned a lot. I'm not a woman, so naturally cervical cancer would not be something you would think I would be very much into. But I've learned a lot today, and I think as a communicator and as someone in the public health space, I have started having ideas in my head on how to use information, and especially statistics that we are getting from sessions like this, to really get the message out there, even simplify it further, and ensure that it eventually reaches every little community, well, as long as they have access to the internet, of course, because we're on online voices here, so we're talking about the internet. And so I think it's really it's giving me ideas and thoughts on how to really break down this message and ensure that eventually we can have the people who really need this information in the suburbs. Someone talked about it right here a while ago, talking about cases of integrating various setups, like people who do not want to go to church, for example, or people who rather go to church and be prayed and have prayers upon, rather than have themselves checked for cervical cancer and issues like that. How do we handle such cases? What do we do with such people? How do we ensure that we can eventually convince such people to ensure that prayers is good, but prayers without action might not be as effective as we think. And action indeed is making sure you are checked and ensuring that you get the right medication and the right treatment and the right whatever needs to be done. So I think this session has opened my mind a lot more to the subject of cervical cancer, and I'm so grateful to the organizers for such an initiative. I get and begin to understand that such events happen Wednesday evenings. So I'm going to be a regular participant in this, and I'm really looking forward to learning a lot more and contributing my little part to ensure that we indeed take the fight against cervical cancer forward. Thank you very much.
Thank you so much. We are very much humbled by your comment, by your insights and thoughts. Thank you very much. And there's one more question. Are there cost implications for cervical cancer? Do I just walk in and go get checked somewhere? Is it free? So that's one question. Another one, has there been progress when it comes to myths? The way after some time we saw progress in HIV screening. Have you seen any changes? Are more Kenyans willing now compared to 5 years ago? Also, what more can be done by us, health advocates? So those are close to 3 questions, and I'll allow the speakers to go ahead and answer before making their final remarks because of time. So, Daktari, would you like to go first?
Yes, thank you. I will start on the cost implications. I think if you've noticed that there are a lot of medical camps that have integrated cervical cancer screening, and probably this is the reason why, because probably if you come to a hospital, let's start with a public facility like NHIS. Yes, will pay for viability, but sometimes you'll find some hospitals NHIS does not pay for pap smear. It will not pay for it, and you'll have to pay for it out of pocket. In private facilities, pap smears can be expensive. You'll find it ranging from maybe 1,500 all the way to some facilities where it's 5,000, 6,000, depending on the facility you go to. That's for screening. That has not, the HPV test is also expensive. It can go from 5,000 shillings. So it's quite expensive to screen for HPV testing. The pap smear, the HPV test, but viability, even though viability at some point is being phased out, especially in developed countries, but we still do it here in Kenya because, lack of access to proper facilities. We're still doing the viability. That one is cheaper. That's why you'll notice a lot of people are integrating cervical cancer screening into medical camps, because they know the burden of cervical cancer and what it's doing, and the lack of accessibility to healthcare services that people have. But the question is, after you have been screened and you found, and the healthcare worker found cervical lesions or found a mass, what happens then, especially for patients who do not have money? I have worked in the oncology unit in my facility, and I can tell you that NHIF has done a very good thing for cancer patients. You know, we might say NHIF has its flaws, but when it comes to patients who have cancer, it has really helped patients, especially because I know getting treatment, chemotherapy, radiotherapy is very expensive. One session of chemotherapy for a patient, depending on the drugs they're taking, can cost from maybe 10,000 all the way to 50,000. If you tell a woman in the village that I am Mami, utalipa 10,000, she does not even have money for registration, which is 50 shillings. What can we do? This is why NHIF was very good to people who had cancer, people who have kidney issues. That is why probably NHIF is very good at its work. It's very expensive if you have any form of cancer, because treatment is very expensive, and it also takes a mental load on the patient, and you see, and the relatives, because telling relatives your patient has cervical cancer, we need 100,000 for this, we need 50,000 for this, especially when it's out of pocket, it can be very frustrating for the patients. That is now when it comes to the cost implications. I've forgotten the other question. Please, Valerie, help me.
Has there been progress when it comes to myths? The way after some time we saw progress in HIV screening. Are more Kenyans more willing to, now compared to 5 years ago, are they willing to come for screening? Also, what more can be done by health advocates?
I will say yes, definitely. And this I speak in form of the urban areas, especially maybe in big cities. You'll find there's a lot of uptake to screening, because people here know what cervical cancer is, what it can do, and what eventually can happen if you get cervical cancer. People know, people have been educated at least, and so them seeking healthcare services, they have a good health-seeking behavior. They want to go and get screened. But still, in the rural areas where people still do not know what cervical cancer is, especially in the deep uko mashambani, so people still don't understand what cervical cancer is. So the uptake there is still a bit low. And also I'm seeing that that the vaccine that the government had rolled out is now going to schools. This is actually it's a very commendable thing, going to school, telling parents that if you will not come to us, we're going to come to you. We really need the children to be vaccinated. So that is something very commendable. What more can we do? It will always come back to educating. Use social media. If not social media, use the community healthcare promoters. It's just educating. You see, once you're educated about something, you're going to have good health-seeking behavior, because you know, I'm at risk of getting this and this, so I should do this and this. So at the end of the day, it's just basically educating the masses. Valerie, thank you.
Thank you so much, Dr.
Just to emphasize what Dr. has very well put out there, to encourage, a healthy, a good health-seeking behavior, we also need to address these fears that people have. If you tell someone to go get screened, the question they ask you is, so then what happens if I'm told that I have cancer? Do I start selling my land? Do I start doing fundraisers? That's one bit that has made people a bit shy to go for treatment, to go for screening, because they don't know what to do with a positive diagnosis. But it's something that, as Secretary has said, NHIF has taken out a big burden out of people on that, because they've covered for treatment. What we are doing again at Kenco, there's a project we are currently doing with our friends from Roche. We are trying to do costing for some of the common cancers, including cervical cancer. We want to have a picture of what does it take to treat from this point to point B or C or D. What does the cost look like? Because then that will help people and just to when you have a target that you're better equipped to attempt to meet it than when you just raising money. You don't know how much you need to raise. You don't know how many cycles of chemo you need to do. You don't know what treatment would look like if the first line treatment phase. You don't know where to go after that. But if you have an idea of the whole spectrum of care, then it becomes easier for someone to even plan, and more so for insurers, because apart from a national insurer, very few other private insurances will cover for cancer treatment. But with that kind of costing, and we know that this is what goes into treating cervical cancer, then they are able to put that in their packages. So we're doing that, and soon that will be out and be able to share with the insurers. So that's probably one of the reasons why we don't have as many people going to screening as we like to see. But about the one having it gone out there and comparing 5 years and now, there is a big improvement in the number of people who are taking a positive step towards getting screened as compared to some time ago. And that's because of the efforts of these platforms like this one that we are in here, being and many other efforts to try and educate the masses about cancer generally. We've seen a lot of positive response from that. On the cost implication, like I said again, there is this new structure that we are hoping will now help meet the beat that NHIF leaves out, because not everybody gets 100% cover as much as we'd like them to. But we now know in the new structure there will be another fund that can be sought if someone clears what their basic primary cover. So we hope that will help people be able to get better cover for the full continuum of care, from screening, diagnosis, and through to treatment. Just another addition, Valerie, I'd like to say, I thank the gentleman from Togo for speaking to us. We've been doing another project to try and map all the digital solutions that are out there in Africa, in all the various countries in Africa, and I think also including Togo. We want to know who is doing what in terms of having a platform like this one that we have here. Are there such kind of platforms across Africa that help people to find more information on cervical cancer, or even help them to get treatment? So we are mapping digital solutions in cervical cancer across Africa, and once that is ready, of course, we'll be happy to share that, and people will just be at a click of a button be able to know where to seek for what kind of help. So I'm sure Togo will also be there. If there's any intervention in Togo, then it will be a part of what we'll be putting in our map. And across Africa, I think we've currently had some interventions in about 16 African countries, but we are expanding that to try and get as many as another 15 from especially the western part of Africa, so that we can be able to have a way to have direct people to correct information, because the internet being what it is has all manner of information, all manner of teachings out there that may not necessarily be very correct, but we want to direct people to correct information where they're going to get proper solutions whenever they seek solutions for cancer treatment and cervical cancer specifically. Valerie?
Thank you. And we also have TZ. Tanzania is also here. This is truly being Africa. Africa is in safe hands, so let's continue the conversation. So if your question wasn't answered, or if you still would like to ask more questions, please go ahead. This conversation will be going on. Use the hashtag #HerReasonForBeing, and we'll be able to answer you promptly. Because of time, can you have... Okay, you may have 30 seconds each to just give a closing remark. Please, Mr. Mapelu, go ahead.
Yeah, thank you, Valerie, and thank you everybody for tuning in and being part of this great movement of trying to educate ourselves and educate our communities about cervical cancer, where to get help, what kind of help is available there, how to prevent it, and how to get vaccination and everything. It is this kind of efforts that help us be able to achieve the main objective of cancer care in this country and world over. So I would like to encourage you to continue on with this and to consult more frequently so that we can be able to know how best to inform our people, to inform ourselves, and of course to inform our communities. Thank you, Valerie.
Thank you so much. Daktari?
I want to say thank you to you, Valerie, our host, or our moderator rather, and Being Africa for being our host. Thank you so much. It's true. This is really a very good platform where we can share education about cervical cancer. We only dream of a cancer-free world, but we're going to get there with things like this. And my parting shot is just anything that you have grasped from here, take it home, take it to your neighbors, spread the information, tell them about HPV, tell them about the vaccine, tell them about cervical cancer. Just tell them whatever you know, because education is really powerful for all of us and for the generations to come. Thank you.
Thank you so much, and I'm very grateful for everyone who joined this session, for the speakers, Daktari, Mr. Mapelu. Thank you so much for sacrificing your time, especially this time of the night, to be here with us, to share with us your knowledge. I'm very much grateful, and to our amazing audience for the lovely contributions, for the lovely questions. Please keep the conversation going, and you may have the knowledge, and if you do not disseminate it or help someone else, then it's useless. So let's continue spreading awareness, and let's eliminate cervical cancer and cancer as well. Thank you so much once again, and let us give it back to our host.
Wow, thank you very much, Valerie, and thank you so much to our speakers and our audience. Thank you, Mr. Caleb. Thank you, our brothers from Tanzania too, for joining in and also giving your thoughtful contributions. Indeed, there is a lot more that is required to be done. There is need for more awareness to dispel the myths and misconceptions that we have out there. And there's also need to raise more awareness to allay the fears, especially for people who are positively diagnosed. Indeed, our reason for being is to inform, inspire, and involve all of us in the fight against cervical cancer. And indeed, together, if we join hands, we can eliminate cervical cancer. For me, I don't have much more to add, but to tell us to let's tune in next Wednesday for our insightful conversation on cervical cancer. And let's keep it a reason for being. Let the conversation keep going on our social media. And if you have any more questions, be sure to post them there. We will respond, and we will ask our speakers will also gladly respond to our questions. Thank you very much, and good night. God bless.
Thank you.